All right, so 78-year-old male with prostate cancer diagnosed in 2010, initially treated with EBRT and ADT, now presents with a rising PSA of 15.1. What's the next best step? There's no right answer, just kind of wanted to see what people might do.
Is this a trick question?
For 3,
Depends what year I
2,
was.
it doesn't, all right. All right, we'll go on. Everyone just thinking in their head what they would have picked. So interestingly, this patient had a flucyclovine PET-CT, and I think this was right around the time PSMA was introduced, and so yeah, biochemically recurrent patient with flucyclovine. It was negative. And then this is the data that comes from Jeremy Calais' study that compared flucyclovine versus PSMA and showed higher detection rates of disease with PSMA. However, in the prostate bed, interestingly, Axumin did perform a little bit better, which, maybe, who knows the significance of that, but I think it's an interesting discussion. What would you do next? So negative flucyclovine in a patient with biochemically recurrent disease, PSA 15.1. All right, answers for the sake of time.
4.
All right, so
Vote again. Sorry.
we'll just go on. I think people will just, for the sake of time. So
That's what we were going to vote for.
yeah, everyone was going to vote for PSMA PET. Great job. They got a PSMA PET and lit up in the prostate gland.
Replace the voting.
I'll be the.
Yeah.
I'll tell you.
So it's interesting, despite what that one study showed, and personally in my experience of what I'm noticing is PSMA PET does a pretty good job at localized disease, and what it's showing in a lot of new studies is really promising performance, and in some ways this might be used for guiding biopsy in the future as well. So comments here, thoughts?
Yeah, I think if that's the only disease, then you start thinking about some other form of local therapy after a biopsy, maybe cryo. If the patient's a candidate and his urinary symptoms can tolerate more local treatment. Oh, pardon me. I think we'd biopsy that if there's no additional disease and think about additional local treatment.
I have one more case. It's quick. 53-year-old male, high-risk prostate cancer, 2017, status post definitive prostate radiotherapy, adjuvant Lupron, lost a follow-up, comes back with back pain, left neck swelling, increased PSA from less than 0.1 to 0.1. What would you do next? So guy, symptomatic back pain, left neck swelling, history of prostate cancer. I don't know, the PSA was really low. So again, no right or wrong answer here. So 100% said PSMA. We got the PSMA PET, and you see disease lighting up everywhere. And you're kind of like, what the hell is going on here? And I think in a case like this, it's probably important to biopsy and make sure the tissue is concordant, just because it seemed a little extreme. So we did biopsy the left supraclavicular mass, came back as prostate cancer with high expression of PSMA. What would you do next? I just told you, we biopsied. Great job, guys.
3.
Yeah. And that's about it. So again, that's a good example of how even at low PSA levels, sometimes like weird stuff happens, and
So
they
that
don't
kind of
redetect
answers
it.
the threshold question,
Yeah,
right?
it kind of answers the threshold. I don't want to like make that just based on one case, but I think everyone has seen it. I'm sure Jeff has seen that a lot as well.
Yep, we definitely have. We got a publication out there a while ago, not in that population, but on late stage heavily treated patients who had failed everything. And about 12% of the time we picked up metastatic cancer on choline, which is obviously less sensitive in the late stage group with a PSA that's undetectable. So, when they become higher grade, they can lose PSMA expression, they can lose PSA expression, or they can lose both. They can do what they want.